Now, you all have had the opportunity to hear from Aging and Independent Services about what our role is with the Community-Based Care Transitions Program and how we are partnering with the 4 largest healthcare systems, Palomar Health, Scripps Health, Sharp Healthcare, and UC San Diego Health System. But what you haven't heard is the phenomenal work that the hospitals are proposing to do under the Community-Based Care Transitions Program. These professionals have brought outstanding talent to the Community-Based Care Transitions Program, and I think it's really important that you hear about the broader system change that they propose to implement, because it's phenomenal. I have never worked with a group of professionals that had such commitment and passion to improving the quality of care and improving care transitions across their healthcare system. And I know you're going to be as impressed as I have been with each of these teams. The second half of the meeting will be devoted to the dual eligible demonstration. You will receive an update on the dual eligible demonstration, as well as a report out from the chair of the Dual Eligible Advisory Committee, and you'll have an opportunity to ask the health plans any specific questions that you may have as well. Now, normally in the meetings, I do provide a little bit of a background on the long-term care integration project, but today we don't have time for that. We have too much to cover. So I will refer you over to our website for some background information if you're not familiar with the long-term care integration project. That is www.sdlpcip.org. Or you're welcome to send me an email. My card is over there, and I'll be happy to provide you with any background information.
Good morning. I'm not sure how much background information everybody here has on the CCTP program. How many of you were at the Learning Action Network meeting a month or two ago? A few, a handful, maybe half. So there are probably people in this room that are going to see abbreviations and lingo that maybe you've never heard before. But I will do my best to explain as I go along. So I'm with Sharp Healthcare, and my responsibility is with case management and social services for the 4 acute facilities in our network. One in the metro region, one out in East County, one in Chula Vista, and one in Coronado. And we are participating with the county as well as the other 3 organizations that were mentioned in the application for the CCTP program with CMS. So what I'm going to do is give you a very brief overview, maybe only about 10 minutes today, on what our program is going to look like and what it includes. So the best way that I could explain the general philosophy of our approach is really it's all about, I'm going to use this instead. Here we go. Teaching patients to become more activated in their own care. And as you can see here, if we teach them how to fish, they'll eat for a lifetime. So I think a lot of us who have been involved in case management have always taken a very traditional approach. I mean, I've been doing this for over 25 years. I'm older than I look. And, we traditionally have done things for the patient. For example, if a patient doesn't make an appointment with their primary after they're discharged, we have a lot of systems in place within Sharp, and I think many other organizations do as well, to get in touch with the patient and make an appointment for them. Or if they don't understand how to take their medications or they're not organized, we go into the home, we do a visit with them where we organize everything for them. So we're kind of really doing it for them, which with some patients might work. The problem with that approach is really, once we're not there anymore, what happens? Often the patient falls apart. So in order to create a sustainable improvement with the patient and their behavior, what we're really all about with our program is really trying to get them more engaged in how to take care of themselves, know where to go for resources, and what to do if they get into trouble. So when we're no longer there, they know what to do, and the first thing they do is not pick up the phone and call 911 and end up back in the emergency department. So this is a little bit about our timeline. Back in, it seems like it's been longer than this. I mean, this is really understated because I think we started this all last year. But anyway, The first time the application actually got into Medicare's hands, I think, was sometime in the spring-summer period, after much back and forth. And just a quick note, prior to this, Sharp was the first facility, Sharp Memorial was the first location in San Diego County that AIS actually did their pilot CTI program. Who has not heard of CTI in this room? Oh, only one person, okay. It's basically a patient engagement model of care transitions, and you'll see a little bit more about what that means as we go through some of our interventions. So we started that, gosh, I think probably back in 2010. That pilot started with a CTI coach who was an RN, actually from the county, and a county employee that was stationed at Memorial, was receiving referrals from the hospital, case management, social work staff, and then doing the CTI model with those patients, following them out into the community. So within the system, we do have experience with CTI. A little bit later, we'll go over what our 4 interventions are. In April and June, we actually had 2 of our own staff go to Denver and attend the CTI training. To become an official CTI coach and be able to use the word, you actually either have to go to Denver and get trained, or someone who is certified as a master coach has to train your staff. So we have 2 folks now at Sharp that have gone through the training. And in July of this year, we actually started a test phase, which has been really helpful to us because it's been very helpful to us because as we're going, we're sort of evolving our process, evolving our criteria. We've got a coach actually out in the field doing this hands-on, and it's interesting because you can go to the training and hear about it, but I don't think you really get an idea about what CTI is all about until you actually physically have to do it. It's very different than what we're used to with traditional case management. So we're testing this at Grossmont. We're doing 2 of the 4 possible interventions. We'll talk a little bit more about that in a second. And as of yesterday, when I put this together, we had 30 patients that we have enrolled so far. So we have 4 intervention options in our package for the CCTP program. The first one is the traditional CTI, which includes 1 home visit. And the primary purpose of that home visit is for the coach to go into the home and help the patient set a personal goal and then also to complete their personal health record. The difference with the personal goal setting in the CTI model is that you coach the patient to get to a goal, but it's really, it's not necessarily a medically oriented goal. In traditional case management or disease management, we might think of a goal for a diabetic to get your hemoglobin A1C below 5. That's very clinically oriented. It's a lab value. I need to do what I can do to manage my blood sugar so that my average blood sugars over time are within an expected range. In the CTI model, a goal might be, I would like to be able to walk to the mailbox without getting short of breath. Or I would like to be able to go to my granddaughter's wedding in 6 months without having to be on oxygen. So you can kind of see the difference there. You really make this very personal to the patient, and then what the coach's role is to help the patient get to the point where they understand today why they can't meet the goal and what they need to do to make changes in their life or their lifestyle or how they manage their disease so that they can actually get to that goal. The patient also maintains a personal health record. It's something that they do. They write it. They write down their medications. They learn how to reconcile their own medicines. They identify what their red flags are. We might say a red flag is that the patient's blood sugar is 150. That's probably not a good example. 250. And the patient might say, I get dizzy. That might be their red flag. Well, what does dizzy mean to them? Probably means their blood sugar is going through the roof. Maybe they're getting a little fuzzy or confused. But you let the patient do this in their own words so that when you're not there, they can refer back to that and understand what it means and have it, be meaningful to them personally. So we do 1 home visit, and then they get 3 to 4 telephone follow-ups, and all the follow-ups by phone are based on the goals and the things that they were missing or needed improvement on in that first visit. We also have a second intervention that, to avoid confusion for Medicare, we have renamed several times, but now we're calling it post-acute navigation services, and basically that's a fancy way to say they get phone calls using the CTI model, but they don't get a home visit. So everything is still very CTI model based. You're still trying to help them on the phone set goals and understand red flags. What you can't do is really get them to do their personal health record. That's very difficult to coach someone through on the phone. But it's basically following the CTI pathways for the coach without doing the home visit. Then we have CTI with care enhancement, which is basically the full CTI that you see in number 1, and then Aging and Independent Services has a program called Care Enhancement. Are you going to talk about that today, or?
No, I think, we've covered that in the previous meetings,
Okay.
and maybe next time around we'll
Okay.
talk about that again.
So the care enhancement's more about the social supports that the patient might need that they don't have in the home. And then finally, we have a program at Sharp, which today they're still calling transitions, but we did actually get a cease and desist letter from the Transition Lenses people saying that they weren't allowed to use that name anymore. So for the purposes of this application, we call it Bridges. It's basically, we'll talk a little bit about it more in a minute. It's for patients who either aren't eligible for or aren't ready for hospice, but have an end-of-life diagnosis. And it's really all about, please put your phones on vibrating. It's really all about advanced care planning and prognostication, and I'll talk a little bit more about what that means in a second. And that's 2 home visits and 4 follow-up telephone calls. So one of the handouts that you got was a copy of what our workflow looks like. Really, I'm not going to go through it in a lot of detail today, but it really kind of outlines how we're going to go about deciding which patient gets which intervention. And pretty much what happens is the case manager, 9 times out of 10, the hospital case manager, will be the one who starts the process. We also have the coaches out there scanning the hospital census every day to identify patients who may be appropriate for one of the 4 interventions. I think when we started all this, we had very grand plans that we were going to apply some evidence-based screening tool, and that we were going to do these tools and patients were going to get scores, and we were going to do all that. And to be honest, what we're really finding is looking for a chronic diagnosis, and then looking at the patient record for what their history is and what you know about their background is probably the best way to screen the patients who are appropriate for the service. Because once patients hit 65, they almost always, if they're in the hospital, they're all going to end up being, quote, high risk using the traditional scoring tools. So once the case manager refers to the coach, or the coach finds someone themselves who may be appropriate, there's a review of the medical record, and the coach then goes in and interviews the patient. And we usually, the first thing we'll do is look for patients who would be appropriate for Bridges. So we're looking for end-of-life type diagnoses. They're not doing Bridges right now with cancer patients for a variety of reasons. So it's primarily heart failure, COPD, and dementia are the 3 target diagnoses for that. If they're appropriate for Bridges, they get referred off into that program and dealt with by the Sharp Hospice and Palliative Care folks who run the Bridges program. We then look to see if they look appropriate for CTI. If they look appropriate for CTI and we talk to them about it and they refuse a home visit, then the next step in the process is to offer them the telephone follow-up. So they would automatically get triaged into that post-acute navigation program. And if they refuse that, then we pretty much just put them back in through the normal discharge planning process. But 9 times out of 10, the patients that we identify will accept one or the other of those options. When we actually get the final program up and running with the county, we would then also, for the appropriate patients, refer them into the care enhancement program with AIS. So who's eligible for CTI? High risk for readmission, which basically means everybody that's in the hospital that's a Medicare patient. They have to be primary Medicare fee-for-service. They can't have Medi-Cal as a secondary. They have to be independent in that they have to be able to actively participate in their care. So patients who are not appropriate for CTI would be a patient with dementia, especially if they don't have an adequate caregiver at home who is willing to participate on their behalf. Because remember, this is all about getting the patient engaged in their own care. So they have to be able to read and write fairly well at probably about, I think we're at about a 5th grade level on most of our materials, and to participate in their care, and that they actually want to participate in their care. We are looking primarily for patients with a chronic disease diagnosis, and they have to be willing to accept a home visit. And if they don't, they would then get diverted into the phone-only intervention. Today, the folks that we're excluding, you can see on the right there, and primarily they're excluded because either it's not feasible to get the home visit in, especially with dialysis patients. You know, they're away from their home so much, especially immediately after discharge. It's very difficult. You know, dialysis for most patients is an all-day thing. And it's really important that these home visits occur very early on and after discharge. We're getting into them within 3 days after discharge to be most effective. Any patient with active substance or alcohol abuse issues is not appropriate for this program. If they are going to a nursing home, we're not intervening with them today. And active mental health diagnoses typically because they are not really able to effectively participate in their care. If they're hospice eligible and end stage disease, then we would refer them into hospice or even possibly the Bridges program. So the post-navigation services are the ones that are telephone only. It's very similar criteria to CTI. It's just that the patient probably refused a home visit, or we deem them as moderate risk for readmission, but they do seem motivated to participate in their own care. And really the rest of the criteria is the same. Mm-hmm.
I wanted to ask a question on the last slide. You say that only Medicare fee-for-service as primary with the Medi-Cal secondary being okay are eligible. This, I assume by this definition, this would exclude all of the dual eligible population that go into the managed care project and are.
That's correct, and the reason is because this program is specifically being funded by the Centers for Medicare and Medicaid Innovation program. It's not a grant. I always say grant because it's easier to explain, but no, this is specifically targeting Medicare patients, Medicare primary. Fee-for-service, not managed care.
But you've got Medi-Cal up there.
Medi-Cal secondary is okay. I'm sorry?
A quick clarification. You have 4 interventions, correct?
Yes.
Yeah, and they're integrated into the workflow, but they're not spelled out as such. Is that correct?
I don't understand.
I don't understand what you're saying, Rogelio.
Well, in other words,
You're
the
asking.
4 interventions, they're integrated into the workflow, correct?
Right.
Yes.
This is the workflow.
That really talks about how we get to the point of triaging the patient into the workflows. It just shows which branch they might be triaged into.
But it doesn't really go into the specific intervention along the workflow?
No, it doesn't.
That's
It basically says the patient gets enrolled in that, and then the next thing you know, they're done after 30 days. That's all you see on the workflow. There are other workflows to talk about the detail, which if I had more time, I'm sure I could go through that. Okay, so the Bridges program, our target population with this is people, patients with chronic illness. Heart failure, COPD, and dementia are the primary diagnoses that we are targeting on this. We say or other end-of-life diagnoses, but really from a staffing perspective, the slots for this program get filled up pretty quickly with those patients. And this is for patients who are not ready or not hospice eligible. So typically, they'd be about 2 years out from end of life. So this is not imminent death, I'm going into hospice tomorrow. That's not the kind of patient that belongs here. These are people who have been diagnosed with one of these chronic diseases, which we know is probably not going to get better. Ultimately is going to be progressive and result in death at some point, likely within the next 2 years or so. Basically, it's proactive disease management that's really focused on end of life. So the things that they do are they go into the home and really work very early on advanced care planning. So they use what is called evidence-based prognostication. So we have physicians that are part of this program that look at biomarkers, which basically means lab results such as your albumin, your cholesterol, several other key lab results, and things like weight and oxygen sats and other things to really give the patient a very honest and clear picture of what they have to face in the future. Because quite often, if you think about how we present hospice to patients, unfortunately, I'm sure the San Diego hospice lady in the room would say that I think we're getting better, but we're not there yet. You know, we're really at the end. I mean, by the time hospice is talked about with many patients, they're very, very close to the end. I'd love to say that we had a 6-month average length of stay in hospice, but I'm sure that we're not even close to that. Last I heard, it was 2 weeks, 14 days, or is that?
Yeah, the average.
Yeah. So what we're really looking at is before the patient gets so sick that their hospice decision is imminent, or the need for hospice is imminent, we want to start talking with them and their family very early on about the reality of what they're going to face, and then help them to make decisions about what they want, because we feel that the earlier we have that discussion with them, the more realistic it will be, as opposed to sort of the last minute panic mode of thinking, okay, you're going to put me in hospice to die.
I'd like to introduce now Cedric Terrell from the Palomar Health System. And Cedric is a pharmacist that's going to have a very active role in the Palomar Health model, and he's going to walk you through their interventions.
Sure.
Thank you, Cedric.
Thank you, Brenda. Make sure I got this right. Okay, well, good morning, everyone. One of the things I want to mention is, for us, we're really excited to partner with all of the hospitals in San Diego County, as well as our colleagues with AIS in regards to this project. For our team, I think one of the things to mention first is we're a multidisciplinary team, obviously, with our physicians being involved in our process. We also have a high-risk healthcare coach that we're instituting for our program, our pharmacy team being part of it, case management being part of our program as well. Looking at our patient throughput process, we identified that really to address the high-risk patients, we really needed to create a process where we would identify those patients by our case management team. So they would do our initial screening, and then based on the screening criteria, they would refer the patients to our high-risk healthcare coach. So on your screen is what you see is our high-risk criteria that we identified. Patients that have 8 or more medications. Now, truly, the definition of polypharmacy in different literature, you can look at it, and basically it can be as many as greater than 4 meds, or greater than 4 new meds on top of chronic meds, or meds that are used as adjunctive therapy for primary meds. So polypharmacy can be a broad definition. But for us to really look at our high-risk patients, we really wanted to make sure we focused on those patients that seemed problematic as they were coming through our health system. Multiple chronic conditions was another criteria that we wanted to identify. Primary diagnosis of AMI, pneumonia, or heart failure. 2 or more readmissions in the past 12 months as a risk criteria, as well as 2 or more ED visits in the past 6 months. As I mentioned before, really looking at what our team consisted of, we took a deeper dive into our target population. We initially estimated about 3,800, a little over 3,800 patients we would identify. Then looking even closer at our target population, we realized that we could reduce our number to get to that high-risk criteria. We could reduce our number by 25%, and that's where you see where our target population reduced from a little over 3,800 to 2,800 patients by refining our target criteria. And this is a moving target. As we continue to get through our processes, we identify who are our true patients that we need to focus our attention on. We even get more stringent with our high-risk criteria. once our patients are identified, then we would really focus on providing a high-risk healthcare coach for target or direct service. That high-risk healthcare coach would then trigger all of the other activities with our multidisciplinary team. And part of that, obviously, is our direct service by our pharmacists. So on the next slide here is the interventions that we've identified that the high-risk healthcare coach would participate or conduct after receiving referrals from the case management. The high-risk healthcare coach would round with our hospitalists to facilitate communication with our primary care providers. They would conduct daily visits with our patient or family to determine barriers to learning and best teaching methods. They would confer with our clinical nurse specialists, our pharmacists, and other patient educators. One of the things I didn't mention, and probably similar to a lot of our hospitals in San Diego, we also have clinical nurse specialists that will participate in our program and help us scrutinize or identify those patients that are truly at high risk or need that additional education in regards to their care. The high-risk healthcare coach would also participate in the verbal handoff to our CTI colleagues and conduct a phone call follow-up. Now, looking at our pharmacist interventions, obviously this is a list of things or expectations that we have for our pharmacists as they participate on our team. One of the things I want to mention as well, currently what our pharmacists do for patients that are, we're actually at one of our 3 facilities, we've already started for patients that are scheduled to be discharged. We automatically provide a discharge counseling service for those patients that our nurses identify are at high risk. And we create right now, there's a web-based program where you can at least help with reconciling the patient's meds and capturing all of their medication history from community pharmacies. So we work with those patients to create that medication profile before they leave. The benefit obviously is in our MedRec program. We have a med reconciliation program where we have medication intake coordinators that work in our ED department. And as we have patients that visit our ED, we capture all of their admission medication history information. That provides a great benefit because a lot of times we have patients that possibly know the name of their meds, but no strength, really know what they're taking a med for, but don't know the name of the med, know the pharmacy that they get it from. So it provides a benefited service where we can actually we provide that sort of like that connect to our community in regards to calling the community pharmacies to identify what these patients are taking and get that concrete or solid medication history list. And then from there, our physicians can reconcile those patients' meds when they're admitted to the hospital. And then on the back end, obviously, when the patients are going home, physicians then can look at that patient's profile and determine, okay, based on what you were placed on in the hospital, here are the meds that I feel you really need to continue. Or I see that you were taking these particular meds at home. You know, we had you on these intravenous meds. We went to an oral process, but really, I want to make sure to avoid the duplicated therapies. So we want to make sure we discontinue these meds. And then with the pharmacist coming behind them, the pharmacist also helps identify possibly where patients are discharged with duplicated meds as well. Okay. So in addition to that type of service, the pharmacist will provide consultative services for the patients, assess the barriers in patient compliance to drug therapy, provide patient education on home medication, and resolve pharmacy-specific barriers. Obviously, one of the barriers, I guess everyone is already aware of the big issue we have in the pharmacy world is drug shortages. Okay, and on top of that, the cost of medications. As more medications move from brand to generic, obviously, manufacturers are doing their evaluation on, is it beneficial for us to continue to manufacture certain drugs? So then you run into a list of, narrowed down spectrum of drugs that are available, and then helping patients identify what are your options in regards to identifying or in regards to receiving some of their medications. So we look for our pharmacists to assist with that service as well. Here's a patient volume breakdown in regards to our interventions, looking at 2 of our facilities. Palomar Medical Center, I mentioned 3 campuses. We have a downtown campus as well as our new facility that we just opened last month. And then Palmerado is our 3rd hospital. So in our total service breakdown, looking at our high-risk target population, we anticipate that the high-risk healthcare coach would in regards to seeing these patients, 719 of these patients will actually be identified by the high-risk healthcare coach only. And then from there, you can see the sort of like tiering effect of the high-risk healthcare coach identifying pharmacist intervention, identifying referral to our CTI partners, or follow-up phone calls, so forth and so on. Okay. And that is it for our presentation. And I know that we got time for questions at the end.
And Dr. Ellis is going to walk you through the Scripps model, which again brings a lot of innovation, creativity to solving a problem on a very broad system level.
Okay, thanks a lot. Care transitions is something we've been working in for several years now, and some of our former and some current partners are here at JFS. We've worked closely with them. So as far as the CCTP or San Diego Care Transitions Program, our target population at Scripps, we have about a little over 20,000 Medicare fee-for-service admissions a year, about a third of our total admissions. And when we did our root cause analysis of readmissions applying for this CCTP, we figured out that about 3/4 we felt were either preventable or potentially preventable. And then within that, 65% of our admissions are unique individuals over any 6-month period. So that's how we came out with our 9877 eligible beneficiaries per year. So looking at our interventions, the first one is something that we're calling our inpatient navigator. This is 85% of our patients in the CCTP program would be receiving the navigator, half of which will be their sole intervention, and then another 34% would be getting multiple interventions. And this is a novel position born out of our own QI, or quality improvement work, called our care management redesign. And it was one part case manager doing kind of the standard discharge planning, which was with an emphasis on care coordination. And again, this is not part of our what we would be billing CMS for the CCTP program. And again, this involves detailed risk assessment of patients, determining why are they at high risk for readmission, what makes them high risk, and then also ensuring mobilization of ancillary providers as part of the care team to ensure smooth, kind of expeditious and smooth transition out of the hospital. The second part is a one-part care transition specialist, and we look at them as really going beyond Medicare's conditions of participation, and primarily initiating interventions designed to mitigate their risk of readmission. So some of these risk mitigation strategies include assessing barriers to learning, including health literacy and other language barriers, reinforcing disease-specific education using TeachBack. TeachBack is something you may have heard of. It's a relatively new concept of where you don't just stand there and tell the patient this is what you're going to do or this is why you're here. You explain it to them, then you have them verbalize it back to you, and so you can see if they're actually hearing and understanding what you're saying. And if they don't get it, then you kind of it's two-way communication rather than one-way communication. So ensuring patients have at least one follow-up appointment scheduled prior to discharge. There's a lot of data out there, particularly with heart failure and COPD patients. Heart failure shows that readmission rates drop if they see somebody in follow-up within 7 days of discharge. COPD, the data is good for 30 days. So again, this is part of our initiative. Post-discharge phone calls for patients not receiving one of our other interventions. This is something that the inpatient navigator would do. Warm handoffs, very big for every member of the care team. Physicians, nurses, case managers, and in this case our nurse navigators, actually calling their counterpart in the post-acute arena, telling them this is what happened in the hospitalization, this is why we think they're high risk, and these are some things we recommend that you focus on in the post-acute period. Ensuring prompt transmission of discharge summaries to primary care physicians and specialty physicians. Again, until we all work in an integrated delivery system where we're all electronically integrated, the need exists to have a warm body actually making sure that the information is transmitted and gets to downstream providers. And of course, this avoids duplicity of care and also making sure that they know what happened during the hospitalization. Second part of our intervention, similar to what Palomar is doing, is a pharmacy intervention. We call it an MTM, or medication therapeutic management. And this is, again, a high-level pharmacy intervention for patients at increased risk for adverse drug events. These are patients with polypharmacy. Our definition of polypharmacy, we're going with 10+ medications. Again, if we used 4, it would encompass just about everybody. And patients who are on high-risk medications such as Lovenox, insulin, or Coumadin, or those who've already come in due to an adverse drug event. about nearly 30% of our CCTP patients would be getting the MTM intervention. 15% of these would be their sole intervention, and then another 13% with the inpatient navigator and the CTI program. And another thing that they do is assess barriers to compliance with their prescribed regimen. Do the patients not have enough money even for their copays? Do they not have a ride to the pharmacy? Or they're kind of unfavorable? Can you kind of anticipate some side effects that may preclude compliance? And then also we want to, again, provide patient education using TeachBack. Why do you take Lasix? Things like that. Another thing is resolving pharmacy-specific barriers to discharge. Affordability of medications, use of low-cost generics, assessing coverage under various insurance plans. Although again, most of these patients would all be in the Medicare fee-for-service Part D, but again, not everybody has Part D. So again, assessing affordability, and then again, a lot of patients who, perhaps those who have less means. There are a lot of patient assistance programs out there, and again, they get the ball rolling in helping them with the patient assistance programs. And then also they prepare a medication list, very concise, because again, our current health information system does not put out a very patient-friendly med list, unlike our UCSD colleagues. I know theirs is quite excellent, but we're trying to compensate for that by putting together a nice kind of spreadsheet for them. And then also for some patients, they do make follow-up phone calls during the 30 days post-discharge, and in extreme cases, we could also do a home visit. And this is a little glance at what, kind of a sample medication list would look like. And, again, it takes physician handwriting out of the equation, which is no small thing. Third intervention is the Care Transitions Intervention, or CTI. 25% of our patients will be enrolled in, we envision enrolling in CTI. And again, so our take on the CTI model starts with a hospital visit where they get introduced to the program, home visit within 48 hours of discharge. Dr. Eric Coleman, who's pioneered this model, speaks of 4 pillars that are kind of around which this model is based. One of which is, does the patient understand their discharge paperwork? Do they have a solid medication plan in place? Do they have follow-up with their post-acute providers? And also, do they have a sound understanding of the red flags of disease worsening and what to do about them if one of those red flags is raised? And then, again, you heard a little bit about the AIS care enhancement model, and that's actually would be our fourth intervention, which would be about 12% of our patients, and almost half of those getting CTI would be referred on to CTI care enhancement, which essentially comes up with a complex social service plan in conjunction with the standard CTI. So again, just a few parting conclusions. One, we at Scripps, we're very proud to be part of this collaborative with AIS and the other 3 healthcare systems. It's really unique. It's been a phenomenal opportunity getting to know some other people in the area and really coming together to collaborate. We just hope we get the funding, because I think there's tremendous learning opportunity from one another in this arena. And again, we look at this as an incredible opportunity to build value in healthcare, increasing quality, decreasing costs. And then lastly, I think there's also a great potential for meaningful clinical research in care transitions. There's a real lack of good data in this area, and again, if we're fortunate enough to get the funding, I think we're going to have a large enough sample size of patients where there's a lot of great research that we can do to further contribute to this field. So, thank you.
Now I'd like to introduce Eileen Haley from the UC San Diego Health System, and she is our last partner in this CCTP application, which, by the way, we did submit an amended proposal to CMS a couple of weeks ago, and we're still in negotiation, but we're hoping to hear a final approval within the next month. Eileen,
Thank
take
you.
it away.
Thank you. So yes, I'm not Anne Marie. I oversee the 3 sites for UCSD for case management and social work staff. And I've sat in on these phone calls, and I must say, bravo to Brenda. It's amazing. I sit in there, my head swims with all the information that circulates. There's lots of good things happening at hospitals, and everyone's trying to look at the evidence or create evidence to show that something works better than something else, trying to minimize fragmentation with, all of our patient population. So UCSD, this is it's a 2-slide. I'm going to keep it pretty simple and short. A lot of what's been said is a lot of what, certainly UCSD has looked at. And we've changed our structure a little bit too to try to better meet the needs of care coordination and transitions of care back to the community. We all know we came from the old kind of case management model where it was very task-oriented, and now we really need to think beyond our walls and do a better job at decreasing the fragmentation post-discharge. So this is a fun slide. This will give you a headache. This is UCSD. The thing, when you follow it, you'll see. So at UCSD, we have our rounds. We do use a risk assessment. We use the Project Boost, the 8 Ps, to try to help identify a patient that's high risk. When you look at the 8 Ps, it's things like the polypharmacy, the frequent readmissions, the poor health literacy, principal diagnoses. So palliative care, if you think that this patient has a high likelihood of passing away in the next year. So we're trying to look at what really is going to get the team to say this person is a high risk and we need to do more. So in the model working with CCTP, we'll be taking our high risk health coach, and she will help pull it together and determine which of the below boxes we'll be looking at for the patients to receive based on what we're finding with rounding and with the risk assessment tool that we're using. So as you can see, we roughly average about 6,000 patients for Medicare fee-for-service. We're a smaller group. We'll have about 3,000 of our patients will need an intervention, and from that we'll determine if it's CTI, CTI plus, CCTP, just phone calls, pharmacy intervention because it's polypharmacy, new medications, high-risk medications like the Coumadin or Lovenox. So this is what we'll be looking at under the CCTP model. It looks complex, but really it's something that a lot of it is what we do now, but the big addition will be the healthcare coach doing more work with the high risk, bringing in the teach back, and bringing in the pharmacist. So to simplify, let's see, this is going to simplify for me. Okay, so it looks like I'm missing a slide. I'm sorry. So to simplify, when we look at the interventions for CCTP for us, we're looking at the high-risk health coach, and that's using the risk assessment, looking at teach back and direct teaching to patients and families. The pharmacist is the other intervention. We right now have a pharmacist that looks at the heart failure patients and does a lot of work with them, so we'll be expanding that to look at the other diagnoses, the other principal diagnoses of COPD, heart failure, cancer, stroke, and diabetes. And then lastly, the follow-up phone calls, which basically they'll be for patients who are not receiving the CTI. You all have a pretty good understanding of what CTI is. That does include the follow-up phone calls, so we'll be doing a pull-out for patients who don't get CTI. We will follow up for this subset of patients to make sure that they're following scripted pharmacy. As we say, we know MedRec is one of the biggest concerns, and those new meds that are thrown at them during the hospital stay, there's no way they're going to be able to pick that up, integrate it, and run with it. So again, we're looking outside the walls. We've changed our model with care coordination to be a little bit more sensitive about the transitions instead of just focused on the concurrent review kinds of things that we've done in the past. So that's it in a nutshell. Thanks.
And so I have asked Donna Braze, our contracts manager, to walk you through the RFSQ that has been posted for home and community-based services. Our goal is to create a very extensive list of potential vendors for various categories of services that we believe will be necessary as we transform the system of care here in San Diego, both through the Community-Based Care Transitions Program, the dual eligible demonstration, and a veterans-directed home and community-based service program that will be starting very shortly, and other initiatives that we anticipate will be coming down the pipe. If I've learned nothing over the last 2 years, it's that take one day at a time, because you can count your eggs one day and you've got more eggs the next day. More and more funding is coming from the state and the feds to really improve how services delivered, and we want to make sure that you all have a part in that transformation in this county. So Donna, if you want to walk these folks through. Yeah.
Or do you want to do it for me, or whatever you want to do?
Would you like to do that
Okay,
with that?
just,
Yep. Great.
Okay, so I'm specifically here to tell you how you can go on in to our county website and view the request for statements of qualification. And that's what an RFQ is. So we will start with the very beginning. What you need to do is to go onto the county website, and there are actually 2 ways of doing this, and I apologize in advance. These screen prints, some of them are a little bit outdated. We've asked for a new one, didn't get it by today, so please bear with me. There are actually 2 ways of being able to go into what you're going to want to find. One is through that A through Z services that you see up there under quick links. The other one is the county departments. So you can actually choose either one of them, even though these slides only choose one. So if you go into county departments, you will look down and find the purchasing and contracting department. If you go to A through Z services, you will look for the B category, go down to the bottom of that, and you will find BiNet. Going on to the purchasing and contracting website, this has changed a little bit. It now says doing business with PNC instead of giving you a direct link to BiNet. But if you just click the doing business with, it will take you to their main page and you will find BiNet on that. So it's just an extra step. Once you go in and you click on BiNet, this screen will come up. And what it is your opportunity to register if you are not yet registered. I understand some of you were at yesterday's meeting, so obviously you are probably already registered. So please bear with me through this. But you click on register and it will take you to this, where you enter your registration. It asks just some basic questions. You set your own user ID and password, fill in the other information, and it will lead you in. So it will tell you when you have finished to click the register button, otherwise you're not going to go anywhere. So you got to click register. And then you'll see this, and you want to go in and register for commodities, because these are codes that then will let you in to the rest of the system. Then you see the commodity screens, and there are dozens and dozens of commodity codes, but this one is listed under one for social services. It is 931-400, and I think there's a couple of extra zeros on there. 931-400. That will take you to community and social services. And then if you want to register for any other commodities, or if you want to get more specific about others that you want to see while you're in here, that's your choice. But we're just telling you for this specific RFSQ and for this objective, you want 931-400. So then, yeah, and this is just explaining more about the commodity codes, which you're free to explore when you're in there. It isn't really, once you know the code that you need, you can go in and hunt around or whatever. I will tell you that if you register for lots and lots and lots, you will get lots of emails. Because this is what the whole system is about, is notifying you of what's coming up for those commodity codes. Okay, so more explanation about the commodity codes. We'll go ahead and come on through this. So then the next thing that you'll see is, getting more detail about that. Come on. Okay, congratulations, you've registered. So now you can go in and take a look. And so then you can go to this next screen, and what you're looking for is that top dot point, review the solicitations. So you want to click on that, and then it will give you a screen where all the RFBs, RFPs, RFSQs are located, And you'll just want to go carefully down that because it's kind of small print. And our RFSQ is kind of stuck in the middle. But what you're looking for is RFSQ 5687. That's the one that we're talking about today. So 5687, you click on that, and hopefully, they're giving you more detail about this list. Once you get to RFSQ 5687, you want to click on that little file folder right there, and it will take you to where this is. You want to scroll on down, find it, and then you'll come to this. And here's where you're actually finding some actual information now. So those little things that kind of look like computers that bottom pointer is going to, those are your attachments. And when you open those, it will give you the RFSQ. If you have any trouble opening this up, the procurement contracting officer, it will be Vera Konstantinova for this particular one. Her name will be right up there where those other arrows are pointing. Her name and phone number and email. So if you have any trouble with opening any of these, please contact her. We don't have any control over opening this up, so she's the one to talk to. And then it should take you to the very first page of the RFSQ. If you don't see it, something like this, where it's a Word document, then you may have trouble. So that's where to go back, get Vera's phone number, give her a call. And this is the end. And these numbers are not reliable at this point because they just moved a week ago. I'm telling you, it's out of date. They moved a week ago, so just go back to the county website or back to Vera's number, call that, and you'll be good. Okay?
And for those of you who received our announcement, we tried to get it out through as many distribution lists as we could come up with. If you haven't received notification of the opening of this RFSQ, believe me, you're in a minority. I think that most everybody has, but we will also be posting that PowerPoint to the Long-Term Care Integration Project website. And again, you have a resource to contact if you have any questions. So now let's move on to the second hour of our meeting where the focus is on the dual eligible demonstration, equally important to the Community-Based Care Transitions Program. And I'd like to introduce Alan Schmeeding, who is the lead for the dual eligible demonstration here at Aging and Independent Services.
And luckily, I have a lot of help from Brenda and many other team members because this is a big job. And there's times I go into denial saying, this isn't really happening. And then I remember where we were a year ago when we were just beginning to hear about this initiative and watching it take shape. And also the last 13 years that myself and Bud Sales and others have been working on integrated care in this agency. And now that it's actually happening, I shared with some folks at the state that it's really very messy. You know, the visioning was the fun part. Now actually putting it into play, I think, is a little bit more challenging. So Brenda just gave me a few minutes, so I'm going to do a quick update, and then I know there'll be some questions and additional time. First of all, I want to share that now we're really talking about the coordinated care initiative rather than the dual eligible demonstration. And this took, being a little slow on the uptake, this took me a while to figure this out. Because for the last year, we've been talking about the dual eligible demonstration. But the new legislation that just passed this past summer in July really created a twofold initiative. One of the parts is, of course, the dual demonstration, where health plans, we have 4 health plans, and their representatives are here today. They're administering the voluntary program. It's a 3-year demonstration, and it includes 8 different counties. And in that 3 years, all these different elements are going to be merged together. The medical, behavioral health, substance abuse and mental health, skilled nursing facilities, and what's really new is bringing in the home and community-based care services. So you thought, okay, well, that's really what we're working on. Well, we're also working on managed Medi-Cal long-term care services and supports. Many of you know that Medi-Cal only have been going into managed care over the last year. So for their medical benefits, they're already a part of managed care. What this does is say that if they want to receive long-term care services and supports, they also have to be a part of managed care. So keep this in mind as we go through, and then there may be some questions, and some of you also may be like me, that it took a little while for the light bulb to come on, that basically anybody who wants long-term care services and supports is going to need to be a part of managed care. Not for their Medicare, for their health, they'll have the opportunity to opt out, but not for long-term care services and support. So I just need to kind of ground you all in that particular element. So the governor had a lot of high hopes for this initiative, and he really wanted to see it roll out throughout the state in the next 3 years. But current legislation only allows for 8 counties, and I think many of you are well familiar with them. The majority of them are in the South, with Orange and Riverside and San Bernardino and LA and San Diego. So we really comprise the bulk of the action, I would say, in this area. The legislation also added really important consumer protections, and I think this is an element that the legislature felt very, very important, was make sure that our consumers have the kinds of protections for appeals and grievances and education that they will really need. The other thing is poison pills. I love to read legislation with poison pills in it. That always makes it super fun. You're like, okay, if this happens, then this, then that. Well, this legislation has several poison pills in it. And basically what that means is if these things don't happen, the whole deal's off. So this part I think is a little bit interesting. The poison pills that are in the legislation, the first one is the feds don't approve the state's cost sharing. The state has identified a fair amount of savings that they expect to see with this initiative. And if the feds don't buy into that, that could be one of the elements that really causes the whole thing not to move forward. Likewise, the next bullet, which basically what this is all about is our state would like to have people on Medicare be a part of the demonstration for 6 months before they have an opportunity to opt out with their health care, Medicare recipients. So the feds are not really in favor of this. We've heard this repeatedly. This could involve major changes at the federal level. Well, there's a poison pill in there related to this element in the legislation. Last week we are on a meeting with the state, and I asked them about that. I said, tell me, what's going to happen with this? Because we've heard the feds are probably not going to approve that. And they said, guess what? As long as we achieve some of these elements, we don't have to get them all. So basically what they were saying is if we get the cost sharing that we're looking for and we get to save the money we need, then we can substitute that goal for the 6-month lock-in. So that was really the first time I heard that once it says in the law, they said, look for the word or. And I said, okay, let's go back and reread it. The other element is that it is not cost effective. So if the demonstration moves forward and it really doesn't save the money that the legislature was promised, the deal is off. Now this one would take effect after the whole program is going. A couple of these are ahead of time, like the cost sharing has to be approved now. And then the most important one is that consumers don't get the care they need. So once again, that's a poison pill that would have to be evaluated after this already takes place. One of the things that we've been involved in is reviewing the transition plan. Some of the others of you may have seen that. This is a document that the state has put forward. They do owe these updates to the legislature. The one is due October 1. We had a chance to comment on it. It's a high-level document, but it's well worth reading on the Cal Dual site. I would say definitely if you have some time to skim through that. There's also 2 more that will be required, and the legislature really wants to keep a close eye on this whole process. And they've given a lot of trust through that legislation for this program to move forward. It's very, very new, very quite significant and large, but they really want to make sure that things are moving appropriately. Integrated services. Here's where we just want to remind you again what we're really talking about, and that is the medical services, everything that the 2 health plans currently cover, Medicare and Medi-Cal, And then the big one for us is long-term care services and supports. So if you recall, I said that if somebody wants any of these, they're gonna need to be a part of managed care to get it. And that will include skilled nursing facility care. The county operates IHSS, and I'll talk a little bit more about that in a minute. Community-based adult services, CBAS. Many of you are probably aware that Disability Rights has filed another action, and there's some other goings on around community-based adult services, formerly known as adult day health care. The other element, multi-purpose senior service program. That's a small case management program. We have 550 slots in our county. We probably need 20 times that. It's intensive and very successful case management for those individuals that are 65 plus. And then other services as determined by the health plans, and I'll talk a little bit more about that in a minute. So carve-outs, I encourage you to go on the CalDual site and look at a chart like this that will totally confuse you. You're like, okay, which group is in, which group is out, they're in this plan, they're not in that one. These are, what I could glean from this, these are the folks that are carved out no matter what, from both the managed Medi-Cal as well as the dual demonstration. Children under 21, veterans home residents, PACE recipients will not, they can join if they wish to disenroll from PACE, but they are not going to have to enroll if they're already receiving program for all-inclusive care for the elderly. AIDS Healthcare Foundation and people with other health care. Then if you really want to know who's in one and out of the other one, and I encourage you to look at this chart on the CalDual site. It's very helpful to get a feel for who is really going to be served in which program. And I think you'll find that interesting. Behavioral health. This is a real important area, and we have George Scolari here, who's been so instrumental in working with behavioral health to try to figure out how are we going to operate these services in our region. Behavioral health funds are not part of the capitated system that will become managed care in the Coordinated Care Initiative. The other funds for those services you just saw are all coming into one pool and forming a capitated rate, but behavioral health is not. They're outside that. The county now operates many of the specialty mental health programs, case management, day treatment, socialization centers. They do fund an IMD, an Institute for Mental Diseases. The important thing I'd like to draw your attention to here is that incentives will be built in and shared savings so that if goals are reached by both the plans as well as county mental health and behavioral health services, the possibility for shared savings is there, and building that in is a very important way to get everybody on the same page, all pulling for success. Now the county has a role here, and as I said, a year ago, if you had asked me, what do you think your role is going to be in a year, I would not have been able to predict these things, though I would have liked to have been able to. Likewise, a year from now, I'm not predicting where we are there either. But at any rate, what will happen with the county is the health plans will work with us to establish a memorandum of understanding, and that will govern our IHSS program. We have about 25,000 IHSS clients, about 20,000 IHSS home care workers or providers, and about 18,000 of them we think are going to meet criteria one way or the other, maybe even more. The other thing that will happen is IHSS basically will not change during this 3-year program, this 3-year demo. And the client will continue to hire, fire, and supervise the care provider. And I really think that that one element is why this program is a part of Coordinated Care Initiative, because this is a very important part of the program to the clients that are served. And that is that they have the autonomy to figure out who's going to provide that care. Our social workers will still do the assessments. The public authority, of which Bud Sales is our director, he's right here, they will continue providing the registry for people who don't have a home care worker, training, enrollment, which includes background checks and payroll. Then we have the Multi-Purpose Senior Service Program. That's the program we operate. We will need to contract with health plans. For the first time, we'll have a contractual arrangement with the health plans to operate MSSP. So that will be something that we'll be working on in the next few months. Now, IHSS will be a managed care benefit. So if someone wants to receive the care and they're not a child, they will have to go through managed care in order to access that care. One of the interesting things about the state law is that plans can request and pay for services above what we're able to authorize through our current regulation. So I think that'll be an interesting aspect, and we'll be watching to see how we can work on that element of the plan. And then the state will continue to serve some roles as they do now for IHSS. They are really the employer agent for payroll, workers' comp, disability, things like that. Oh, yeah.
Just to be clear on IHSS, it's a Medi-Cal managed care benefit, so it's not necessarily duals, it's also just the Medi-Cal fee-for-service.
Thank you. And I
Same
think,
with community-based adult services is a Medi-Cal managed care
yeah,
benefit.
do you want to stand up and help me reiterate
No,
that
no, no,
point?
I can-
Okay. Did
I just
everybody
started thinking
understand
it's
that?
like-
Yeah, and I think that was the point I was trying to make about the two initiatives, that it doesn't matter which one you're looking at, the duals demo or Medi-Cal managed care. If you want to access IHSS, MSSP, skilled nursing, and CBASH, you're going through managed care. And so we'll just, I know it's going to take a while, it certainly took me a while for that to sink in. And then a big news for us here in the IHSS world is that there will be a new entity formed at the state level to do bargaining for the home care workers. And we have about 20,000, as I mentioned. Well, the state is forming an entity to take over collective bargaining. So once everyone enrolls into the demo and into managed Medi-Cal, well, then all the providers will be moving into this new entity who will be, actually they won't be moving, but the labor unions that represent them will now be working with the statewide entity. And that's something that our local public authority has fulfilled over the last 10 plus years. Universal assessment tool. This, I lost track of how many legislative bills were introduced asking for universal assessment over the last 20 plus years. This has always been a dream, that clients would only need to go through one assessment for all these services. And this is actually moving towards reality. The process will begin next June. I encourage many of you, once they call for stakeholder involvement, to sign up and be a part of the process so that we can help with that design of the universal assessment. It actually will not come into fruition until January of 2015 though, so it's not like really right around the corner. But it will be used for elements of the new system, daycare, CBAS, MSSP, IHSS, but not for skilled nursing. I think everyone's well aware they have other licensing requirements and other assessments they need to do. This is a big area for us in that we're real hopeful that the plans, when they realize how much money they have to spend, will be able to purchase some additional home and community-based care services. And some of the ones that are in the legislation are listed here. We really are excited to think that that might be a possibility in addition to the other services that will be mandated for plans to provide. So we're just waiting, and we know that once the plans find out what the rates are and how much money is available, that's when some of these discussions will happen. Person-centered care coordination. Over the last 13 years, we've always felt really strongly that the secret to success for individuals in the community, especially those isolated, vulnerable people who don't have family supports, is really having a case manager to assist them with meeting their needs. So that process is going to happen through, there'll be a risk assessment that the plans will utilize. The wonderful thing about it is that the client or the consumer or the recipient has the primary role to make decisions, and there will be interdisciplinary teams, including county staff who are serving these individuals now, and the case management will include linking them to services in the community. It also, the law talks about MSSP-like services, and we're not exactly sure what that means. That's just an element that we're still exploring to try to figure out how that's going to work. But I think this is a really important element of what's probably going to make the system successful, is especially for those high-risk people. Not everybody will need case management or care coordination. Many people can serve that role themselves. Communication with consumers. Everybody we know that's impacted is going to get hit hard with communication. But frankly, a lot of it's going to be by mail, and we've heard that that wasn't the most successful communication strategy with the managed Medi-Cal rollout for health. So one of the things that will happen, 90 days, they'll get an update saying, guess what? Keep your eyes out. Your enrollment material is coming. 60 days, they'll get the whole packet. And we understand that will be in alternative languages, alternative formats. And then 30 days before they'll get another reminder that said, did you get that other packet? And hey, what do you think about getting involved with that? One of the things we will all have to do is get the word out through our channels. Every one of you in this room knows these people, works with these individuals. And I think CBOs, our organizations, are going to be the secret to success, really helping people understand what are they going to get out of this system? How is it going to benefit them to have coordinated care? I think that's a role for us to play. One thing we're hopeful is that the state will apply for some additional funding that would be used for our high camp to do some education of individuals so they really understand all the nuances. They would be a very fair and impartial party that could help with this. And so we're like this. The state cannot apply until the MOU with the feds is completed. So the likelihood of them applying in November, we hear from the state, is very good. Timeline. I love to do this slide because I love to change it every single time I do it. I'm like, yeah, let's put this in, let's take that out. One of the things we heard from the state last week was we expected the MOU between the state and the feds to be approved. Massachusetts has. They're the only state out of the 15. I was told California would be number 2. I'm kind of wondering about that because it was supposed to be done in September, and now we hear, I was told early October. Well, you know, I just put October instead of early October. And then we hope that that gets completed in October. Then the health plans will have a readiness review, and that basically means they will be entertaining people of all types who will be doing desk reviews. They're going to come to the building. They have extensive pages of readiness criteria they're going to be reviewing, and I understand that's October, November. And the state shared with us that they really hope to get these contracts done by the end of the year, and I think they meant calendar year. So we really do expect that to happen the end of December. The last bullet said March to June, things would start happening and the initiative would begin. I took that March out and just left in June, because last week when we were up at a summit, there was nobody talking about March. They were all chatting about June. And so that is pretty much an update for now, and we'll keep giving updates as we keep learning more, and thank you.
Hi, my name's Greg Dole, and for those of you I have not met, I'm the longtime Executive Director and Chief Counsel of the Legal Aid Society of San Diego. I specialize in health policy, and I also run our Consumer Center for Health Education and Advocacy. Like Ellen, I have been greatly aided by Brenda, and if you'd like a short blurb about the advisory committee, you actually already have it. It's the sheet that was passed out today. You turn it over. The last paragraph describes very briefly what the advisory committee is set up for. And let me just be really clear. One of the things that Dr. Nick brought up about opportunities of health plans and hospitals and being able to try to all get to this population and really do the best we can for a very sick, very elderly, very vulnerable population that's making this transition. We have a lot of us believe we have a little head start here in terms of the collaborative working together. The legislation requires that any individual health plan that is going to participate in a duals project or here the CCI is required to have an advisory committee of stakeholders in the community to advise it on all manner of things. This is going to be a very interesting time. I tell everybody who works with me in healthcare, it's really exciting. It's also really scary because we're doing a lot of things that a lot of us have talked about, Ellen, for 13 years, but now we're going to really start to do it, and that's always scary, and you don't want anybody to fall through the cracks. But the collaborative effort under Healthy San Diego that the Medi-Cal managed care health plans now all exist under decided that the health plans, instead of having 4 different advisory committees, would have one. The membership now is a little bit pushing closer to 50 than it is 40, and they asked me to chair this wonderful group of kittens that are all together to be herded once a month. But they do a great job. Primarily what this committee is trying to do is to get information that the health plans think they need, to get to hear from all providers, to know what is available. This is a brave new world for health plans. They're not used to providing some of these services, particularly the in-home supportive services, the long-term services and supports. It's going to be, they have to get up to speed, and that's been the real key for the advisory committee. We are not created by anything other than the desire for the health plans to get some information. It's not a Brown Act covered meeting. We do want to limit any more members on the committee only because getting through 2 hours a month with 50 people talking is difficult at best. However, I have always encouraged communication directly with me or with Brenda on questions you might have, on input you might have, on some things you think the committee ought to be addressing. And we always welcome people to come and attend and observe. And we have many of you observing at these meetings. The meetings are always the first Wednesday of the month. And they are, hello. And they are from 9:30 to 11. They used to be at the county administration building. But because there is some planned construction that's going to happen and a closing of one of the parking lots, we're moving the meetings. They're still the first Wednesday. We're moving them to somewhere in this complex. And where is the October one?
Right here,
In this room?
In this room.
And then, didn't you put out, Chris?
October one then is downstairs on the first floor.
Okay, great. So they will be here, and we encourage you to come and observe. I'll give you an example. At our September meeting, what we did is we got updates from the members on all of the state work group meetings, the beneficiary notification, provider outreach and engagement, LTSS and IHSS have been merged, behavioral health integration, fiscal and rate setting, quality evaluation. And then we had some very helpful presentations. We had one from the San Diego Senior Alliance, and a very helpful one from Bud, Pam Hoy, Richard Lawrence of UDW, around the gaps in services in IHSS. And this was information well received by the health plans. They realize that they have to come up with a package of services for each individual that's going to be assigned to them, and getting that and paying for it when they don't even know what their rates are yet. That hasn't even been negotiated. So this is really a learning process, and I encourage you all to help us learn. Thanks very much. Appreciate it.